Hello, everyone. Welcome back to our free live session today. We are on day 36 out of the 90-day NCLEX review sessions. And for those who just started joining us, we are inviting you to enroll to our NCLEX review course at Stancoast NCLEX Coaching. And you can gain access to so many resources, and we are offering about 3,000 NCLEX style questions and 10 hours of animated videos. And also to help you with your confidence, we can also give you the access to our on-demand video library, and we have the practice exams as well. So we really want you to visit our website at stancoastnclexcoaching.com, and if you can also check the description box below, and we welcome your comments, your questions, and also your feedback. And please don't forget to subscribe and like and share this video with your friends as well. Now, for today, we are going to talk about the angina pectoris, which is basically closely associated with a coronary artery disease. And so we'll be focusing into that topic today, and same thing with the NCLEX questions. Now, let's get started right now. We know that the angina pectoris really is kind of like a chest pain, right? Which can occur due to a myocardial ischemia. And it simply means that the heart muscle is not receiving enough blood and not getting enough oxygen. All right. And so this is going to be a temporary kind of occurrence. I'm talking about the ischemia here. And this is caused by the imbalance between the heart's demand for the oxygen and its supply. All right. Now let's talk about the different causes of angina. There are many. And one of those is the atherosclerosis, wherein this is the most common cause. And this involves the buildup of the plaque, which is a combination of the fat, the cholesterol, and other substances inside the coronary arteries, which can really reduce the blood flow to the heart muscle. Now, another is the spasm in the coronary artery. And the spasm that we will be talking about here is a temporary spasm. It will occur as a sudden narrowing of the coronary artery, which can also decrease or can also block the blood flow to that part of the heart muscle. Okay. And unlike the atherosclerosis, the coronary artery spasm will have a permanent type of narrowing of the arteries. And while the spasms are temporary, which can occur even in the arteries that are probably free from any of those plaques. Okay. Now, there are also some conditions that may increase oxygen consumption, and that would be the next cause. And it could be one of the following. Let me just test my pen right now. So part of the causes right here will be conditions increasing the myocardial O2 consumption. And one of the following here could be the hypertension, okay? High blood pressure. And another is hyperthyroidism. Okay, let me just write them out here for you. Hypertension, hyperthyroidism, wherein there is an overactivity of the thyroid gland, and there's excess production of those T3, T4 hormones, and it can increase the heart's workload because of the need for the oxygen, right? And of course, the demand will exceed the supply, which can lead into the angina. Now, talking about the treatment goals here, we really want to make sure that our aim in treating this patient is to relieve or alleviate the pain during the acute episode, okay? And so there are so many things that we can intervene or we can use to cause pain relief, or maybe to allow vasodilation of those involved coronary arteries, and also to involve or to include increasing blood flow to the myocardium. Okay, so we're first gonna have to alleviate the acute episodes, and this is basically treating the pain. Okay. Good morning, everyone. For those in their morning, and for those in the US, you have a good evening as well. All right. We just started just a few minutes ago, so kindly stick with us. Now, part of the treatment as well is to correct the oxygen supply and demand, because there is that imbalance in the myocardium. Okay, there is an increasing demand, however the supply is reduced. There is a lack of oxygen supply. There's also a lack of blood supply to that involved myocardium because of that blockage, partial blockage, or insufficiency in the blood flow to that myocardium. Now, another treatment of a goal here is to prevent any progression of the disease. Okay, this is very important, guys, that we are going to prevent any more complications to occur. We want to control that, possibly by doing a much more of a long-term care, long-term management. Okay, so I'm just presenting this right now way ahead of time, so we will understand really what our role is. Okay, so during the acute phase, we really want to alleviate the pain the patient is experiencing the acute episode. And the second one is we're also going to correct the oxygen supply demand imbalance. And then lastly, we're going to have to prevent the disease progression. We're going to have to treat the patient, of course, with that. It will involve a much more long-term therapy. It will involve controlling the underlying causes of the angina, and also the atherosclerosis. So here we are going to have to manage the patient's condition with administering or teaching them how to properly use the medication to manage their cholesterol, their blood pressure, their blood sugar, and also we're going to incorporate here lifestyle modifications, including their diet, changes in the exercise, and also for those who are smokers, we are encouraging them to stop smoking in order to improve their recovery. Now, the ultimate really goal for the treatment is to reduce their risk of developing the myocardial infarction, because it can possibly be the next complication that might occur to this patient. Okay, we really want to make sure that all these possible complications are prevented. All right, let's move on into our next concept here about the different types of angina. So we have the known four. We have the stable, unstable, variant, and intractable type of angina. Now, just want to emphasize here that variant type of angina is what we call as the Prince-Metal's type of angina. Okay, now let's go over into the different characteristics here as far as pain quality. So what do you think would be the type of pain that a person with a stable angina complain? And so most of the time here, they're gonna feel that pressure or tightness in their chest, like someone is squeezing it, and it often happens during the physical exertion or stress. Okay, please take note of that. So the patient with a stable angina, they're gonna feel the pressure, that squeezing sensation, and the tightness as well. There is heaviness, and this is going to occur mostly during stress and also during physical activity. And with that, unstable, let's compare first according to the pain characteristics of the quality. With the unstable type of angina, their type of pain or the quality of pain is similar to the stable angina, but it is much more intense, much more severe. And this can occur at rest. Okay? Occurs at rest. Whereas here, it occurs when there is increasing stress or physical activity. All right, so see the difference here between the stable and unstable angina? For those who just joined us, welcome to the class. I believe that two of our newcomers, yeah, I just recognized your name right now. Welcome, Adiola and Noah Kyogo. I hope I did not mispronounce your name. Now, here in the variant or the Prince-Mittal type of angina, the pain here is much more sudden. It is going to be severe. That can hit the patient at any time. So it is going to be sudden. The patient will not be able to foretell when it's going to happen, right? It is going to be sudden onset. And even when they're resting, this can occur. And again, the reason for this kind of Prince-Mittal type of pain or the variant angina, this is going to be caused by spasm in the coronary artery. Coronary artery, let me just shorten that to CA. And this is going to be triggered possibly by stress or cold weather. All right, so it can occur anytime, but can be triggered by stress or cold weather. Now, we also have the last type of angina here. According to the quality of pain or the characteristic of pain, the intractable type of angina is somewhat very difficult, okay? It will be severe, it is going to be persistent, and the pain will become chronic because it will be on for the longest time. It will not respond to any of the usual treatments, okay? And here, the person will be impacted with the quality of life, the activities of daily living because of the chronicity of the pain. It comes on and goes, but it happens most of the time, so it can really impact their daily life. Okay, so think about that severe, persistent pain. And let me put it right here. Doesn't respond to usual treatment. So that's the characteristic about the intractable angina. Now let's talk about the cause here for the stable angina. What do you think would do that? Well, even so that this is like the most, probably the mildest form of angina pectoris, still the heart here is needing more oxygen this time, but it's not getting that. And again, this is going to be triggered by stress, could be emotions, physical activity, could be heavy meal. Take note of that. Because when there is a heavy meal, then what's going to happen is that there will be some kind of like a shunting, or maybe the blood flowing. Supposedly the blood flow should be maintained where the need is, especially in the myocardium. But if the person will end up having a large meal, there's some kind of like what do you call this? Diversion of the blood flow into the full stomach. Now, it can also impair the oxygenation to the myocardium around that time. Now, talking about the angina pectoris, this will occur suddenly because of a sudden blockage in the coronary artery, or it could be caused by a rupture of the plaque and will end up with the formation of the thrombus, that blood clot, which will eventually block that coronary artery. Okay, so it will impair the blood supply to the distal part of that myocardium. Okay, now what about the variant type of angina pectoris? What do you think about the cause here? Well, it is caused by the spasm in the coronary artery. Like I said, it can be sudden in its onset, and it can occur anytime. Could be at rest, or it could be at nighttime when the patient is resting comfortably. Now, guys, take note that the distinction between the uh, what do you call this? Not STEMI, okay, and also the angina pectoris. It's basically based on the presence of the cardiac enzymes. Okay, I'm just gonna put in some more concepts here while we are talking about the differences. And so the distinction between the unstable angina and non-STEMI type of chest pain, it's because of the presence of the cardiac enzyme, wherein there is elevation of cardiac enzymes in MI, whereas in the variant type of angina, there is not such thing as elevation of the troponin, okay? Compared to the MI, wherein they're going to have release of those cardiac enzymes like the CKMB or the troponin into the bloodstream. However, in the variant type, there's none. Now, here we're going to have to talk about the intractable type of angina pectoris here regarding the cause. What do you think would lead to that? Well, the cause of pain in the intractable type of angina is linked to a severe coronary artery disease that is very resistant to the treatment or any medications. And so the blood vessels or the coronary arteries are severely narrowed, and so it will be really hard to relieve the pain because of the severe narrowing of the coronary arteries. Now, talking about the radiation, what would be the characteristic radiation whenever there is a stable type of angina? Well, it will radiate to the left arm. It can also radiate to the neck, the jaw, and also the back. All right, so those are the typical sites of radiation in a stable angina. Whereas when we are talking about the unstable, yeah, it seems like there will be similarity here between the two. There will still be radiation to the arm, to the left, specifically to the neck, the jaw, the back, but it can also vary based on how severe the artery blockage is. But again, they're still quite similar. But if we're talking about the variant type of angina pectoris, this is going to be less predictable as far as the radiation, but can radiate significantly as well. All right. Now, as far as the intractable type of angina, it can also radiate to the arms, the neck, the jaw, the back. Not a whole lot of differences. Now, as far as the duration here, this is where we're going to have to base our clinical assessment. As far as the duration for the stable angina, this will last less than about 15 minutes. Typically less than 15 minutes for the stable. Whereas in the unstable type of angina, it will be longer than 15 minutes and may not go away when a person starts to kind of stop doing any activity. When they try to rest, they're going to have to have much more of having that prolongation of the pain sensation. And they're not probably going to respond to the nitroglycerin either. All right, for those who just came into the classroom, welcome, welcome, welcome. Now, moving into the variant type of angina here, what would be the kind of duration? Well, it will be much longer for the Prinzmetal or the variant type. It could be longer than 15 minutes, so it could last about 15 to 30 minutes. And it can happen at times, let's say, early in the morning or when the patient is relaxing. Okay, again, it is very sudden. It can come in clusters and it can come more frequently during certain times, especially early in the morning. Now, moving into the intractable type of angina, as like I have said earlier, it is going to be chronic and it will be frequent. And so the frequency, the episodes of the pain will last longer. Okay. So it will last longer, prolonged, and will not be relieved by the standard treatments. Now, the persistent type of the pain, okay, in the intractable angina. Again, this is very difficult to relieve because the blood vessels, the coronary artery is severely narrow. So it's not really going to respond to the nitroglycerin. Okay. For the relieving measures, what do you think could relieve the pain in the stable angina? We already know that it can be relieved by simple rest and also the self-administration of nitroglycerin or the nitrostat. This will help relax the coronary arteries. This will widen the coronary arteries and will eventually improve the blood flow of the heart. So it's quite simple. It is responsive to the regular rest and nitroglycerin. However, when we're talking about the unstable type of angina, sometimes it might respond, sometimes it might not respond to the rest or the nitroglycerin. And this patient probably would need much stronger type of pain medication such as opioids, maybe morphine sulfate, okay? And for this patient that has unstable angina pectoris, they're going to require much more of treatment in the hospital setting in order to manage the severe pain and also to prevent possible complications. And of course, the patient will be advised to be admitted in a nursing floor where there is continuous cardiac monitoring. And also, we are going to have to establish that IV site, make sure that we are delivering oxygen to this patient because they're going to be probably be hypoxic, and this will compromise all the more the ischemia. Now, we're going to have to control the patient's pain, probably with the use of the nitrates still, with the use of the opioids. And the treatment here will be much more aggressive, okay? Because it will have that kind of similarity with the MI type of pain, but like I've said, with the diagnostic tests that will be used, let's say the CKMB, the troponin, that will kind of differentiate between the MI and the unstable, but the characteristic of pain is quite similar to the MI. Now, we're also gonna include in the therapy early on, upon the acute phase, upon the arrival of the patient, when they suffered the chest pain. The treatment will not only include the opioids, the nitroglycerin, but also the patient will be needing aspirin. Okay, this is very important, guys. And the aspirin is going to be a bigger dose, let's say 325 milligrams PO, antiplatelet medication, and maybe the medical provider will administer or will order the clopidogrel, which is basically the Plavix. And the reason for that is to prevent further complications such as thrombosis. And this is to reduce the incidence of MI in patients with unstable angina. As we know that if there is an inflammation going on during an angina episode, it can cause some more of that clot formation. And this is what we want. This is what we want to treat. Okay, we don't want any more thrombosis to occur, which will complicate into myocardial infarction. Now, this patient would really require emergency procedure, could be revascularization or maybe the percutaneous transluminal angioplasty at that time. And we will talk a little bit more of that later on in our treatment phase. Now, in the acute phase, the patient will also possibly receive the beta blocker. And the reason for that is to decrease the excitability of the heart muscle. We want to decrease the workload of the heart muscle, and this will also decrease its demand for oxygenated blood. All right, so the beta blocker will kind of help relax, decrease its excitability, so there will be a much less consumption of energy by the heart, or less consumption of oxygen, or less need for oxygen, I should say. Now, talking about the Prinzmetal or the variant type of angina pectoris, let me erase this one. Well, the relieving measure for the variant type of angina, we're going to expect here the calcium channel blockers, and still we'll see the nitroglycerin. And why is it calcium channel blocker? Remember that the cause of the pain here is the spasm. And the calcium channel blocker will cause the smooth muscles in the blood vessel, the coronary artery. It will help it to relax. Okay, so it will be effective in treating this kind of chest pain. All right, calcium channel blocker will help relax the muscle layer of the blood vessel and also relaxing the heart tissue. Okay, remember that there are 3 different layers in our heart, the arteries, right? We have the intima, the endothelium. We also have that muscle layer and also the externa. And we have that contractile layer, which will respond to the calcium channel blocker. All right. Now, as far as the EKG changes here, take a look into our table. We're almost through. All right. So here you're going to see some ST segment depression, and this is going to occur during the acute episode, okay, when the patient is experiencing the chest pain. There is going to be ST depression, and the reason why they have that, it's because of the subendocardial ischemia. Subendocardial ischemia. I have very few spots to write this time. Meaning that the innermost layer of the heart muscle is not getting enough oxygen. Okay, so please take note of that. ST depression during the acute episode simply means that there is that lack of blood supply into the innermost layer of the heart muscle, subendocardial ischemia. Now, take note, guys, that this ischemia is reversible. This is transient, okay? Temporary, reversible. So that's why it's very important for us to really treat the acute chest pain in order to not prolong the poor blood supply into the myocardium. We really want to promote vasodilation into the coronary artery. Okay, because if you're just going to let it happen without treating, then the prolongation of the poor oxygenation to the muscle tissue can lead to infarct and also necrosis. And we don't want to get to that point. Okay, we want to prevent that complication. Now, this ST depression, like I've said, is going to be temporary. It will return to its baseline pattern after the symptom has been resolved. Let's say, for example, giving them the nitroglycerin or letting them to get some rest. Okay. Now, in the unstable type of angina, the EKG change probably would be similar. Let me just erase this so I'll have enough room. There's also going to be ST segment depression, but there is an additional T wave inversion. So the package includes now the T wave inversion on top of the ST segment depression, which simply means that there is now an ongoing heart muscle ischemia. It's progressing. Let me just shorten that as ongoing ischemia, T wave inversion. So it simply means that there is now much more severe and widespread subendocardial ischemia. And like I have said earlier, the cause of the unstable angina, it's because of a rupture of the atherosclerotic plaque that may also lead to that thrombosis or blockage of that clot into that very tiny passageway. And so the occlusion will now much more cause some severe effects, much more of, I should say, much worse of ischemia. It's just simply like that, okay? So the tissue now is much more kind of suppressed. It's not really getting enough more oxygen around this time. Now, moving forward with the variant type of angina pectoris, but before I do that, let me erase this. Let's talk about the variant type of angina pectoris. As far as the EKG changes, what you're going to see here will be some transient ST segment elevation. ST segment elevation during the acute episode of chest pain. Now, this is really going to be worrisome, right? Because we're going to really think that maybe the patient is having an MI. But guys, the ST elevation is transient. It's not similar to the MI, which is basically kind of like consistent, okay? It's persistent, I should say. So here, for the variant type of angina, the ST elevation is transient. It is temporary. However, in MI, the ST elevation is going to be persistent. So that's the main difference between the Prinzmetal angina and the myocardial infarction. So please take note of that. So the variant type of angina ST segment elevation is going to mimic. It looks like the patient is really having an MI, but the occurrence is very temporary. All right, now let's move on to the next one, which is the intractable type of angina pectoris. What do you think would be here? Well, the EKG finding in the intractable angina pectoris will be persistent ST segment depression. Persistent ST segment depression. There's also going to be T wave inversion, guys. And sometimes they will have that pathological Q wave as well, which means that there is now long-term heart muscle damage from the chronic ischemia. So let me add that over here. There is that pathologic Q wave. It simply means that the person has a long-term muscle damage from prolonged ischemia, pathologic Q wave. And this is on top of the persistent ST depression and also T wave inversion. All right, so I hope that you're able to capture some of these newer concepts if you have not learned this in the past. So make sure that you will be able to recognize those key features, especially in the EKG changes between the unstable, the variant, and the intractable type of angina pectoris, the treatment, the duration of the pain, the radiation, the cause, and the quality and the characteristic of the pain. Now here, we're going to have to move forward with talking about the different manifestations. Well, of course, the patient will end up with the shortness of breath, right? And the reason for that's because of the patient not getting enough oxygen to meet the bodily demands. Also, the heart function is compromised. It can also affect the lungs, leading to this problem. Now, the patient in the acute pain, they're going to have pale skin, especially when there is now reduction of the blood flow to the heart. It can trigger the stress response, which will also cause vasoconstriction. All right, now this can give that ashen or pale color to the skin. Pale and ashen color. Yeah, I don't like this ashen color. I've seen patients that are like in that moment that they're probably going to code. Oh, gee, I don't like the color of their skin, really. I mean, it's like ominous sign that they're going to code. Hello, everyone. For those who just started joining us, or for those newcomers, welcome to the class. Now, there's that narrowing of the blood vessels, which can really cause that ashen color or the pale color of the skin. And The reason for that is because of the blood flow being redirected to the vital organs. Now, another is the sweating, diaphoresis. Yeah, I think I just kind of like underplayed this one, but this is basically diaphoresis. Beads of sweat. I think that would be more appropriate word to apply in this scenario. There will be diaphoresis, and the reason is that this is the body's normal response or expected response triggered by the activation of the sympathetic nervous system when the heart is under strain. So this is caused by sympathetic nervous system stimulation. And the person will also have some palpitations, also rapid heartbeat. They're really going to feel their chest bounding. And this is to compensate for the reduction in the blood supply. And they're going to feel this palpitation. Well, same thing with the rapid heart rate. Dizziness and fainting will occur. And the reason for that is because of the insufficiency in the blood flow to the heart. And also this can reduce the overall circulation to the brain, which will lead to the dizziness or even the fainting. And this will really happen because the heart is not pumping effectively and causing a reduction in the blood supply to the brain. Now, the blood pressure will also be elevated. Imagine when there is sympathetic nervous system stimulation, this can also can lead to the hypertensive episode, okay, because of that vasoconstriction caused by the pain as well, that very painful sensation, and also the stress combined. And this will further cause a more sympathetic nervous system response and more of the vasoconstriction. So if we're not relieving the pain, it can worsen. Okay, it can worsen the oxygenation to the distal part of the myocardium. Now, another assessment finding that you probably see in this patient will be digestive disturbances. So care providers probably would will probably misinterpret this as a digestive issue. Maybe they're going to refer this as an indigestion, nausea, abdominal pain, and some of the care providers probably would just ignore, hey, that's just hyperacidity, or maybe you just ate something that could have aggravated the abdominal pain. But yes, patients with angina pectoris can also manifest this because the nerves supplying the heart and the digestive system are interconnected, and the heart pain can be referred to the abdomen. And so please do not ignore any of these digestive signs or manifestations. Now let's talk about here the different diagnostic tests, and they're quite similar with the different disorders that we had mentioned in the past. First is the 12-lead EKG, and the purpose for that is to capture any weird abnormal electrical activities of the heart. And of course, we're going to capture those ST segment elevation or B depression or Q wave, pathological Q wave maybe. We're also going to do this testing, especially during the acute phase. So let's say, for example, you receive the patient from the emergency room because of the chest pain, and then you've been taking care of this patient for the last 5 hours, and then all of a sudden, this patient has pain recurrence in the chest. And we're going to need to do another EKG around this time, as ordered by the medical provider, in order for us to capture any changes in their heart rhythm. Okay, so we're going to have to look for that pathologic changes in their heart rhythm. Okay, so ST elevation, that would be persistent, and that could be a sign that there is now MI. Now let's talk about the stress testing here, which is also common. This is going to evaluate the heart's function when they are under stress physically, or when they're running on the treadmill, or let's say when they're given a medication to cause stress into their heart. And this will identify the ischemia that might not be seen when they are at rest. Now, when we're talking about stress testing, it could be in a form of like exercise, like when they are on a treadmill, right? Or let's say they are on a stationary bike while their heart rate and the blood pressure or their EKG are being monitored. Now, there's also that pharmacological stress test. They're going to be given the dobutamine, okay? So we have the physiological or a physical type of stress test. Physical, wherein they're going to be running or on a treadmill or a stationary bicycle. But there's also that pharmacological stress test, wherein they're going to be getting dobutamine or adenosine. So these are medications that can be given if the patient is not able to use the treadmill, if they have some impairment, they really cannot run or walk on the treadmill. And so this will mimic the exercise. Okay, so this patient here will be checked as well with their vital signs. The patient's cardiac activity will also be continuously monitored around this time. Now, the thing that we need to watch out in the stress testing are the indicators of the ischemia. Of course, if they're going to start complaining about the chest pain, yeah, that's quite significant, guys. So if they will complain, hey, I am having the chest pain right now, so that simply means that the heart is not getting enough blood. All right, so what's going to happen is that the treadmill exercise will be stopped. Also, there's going to be some EKG changes. So similar to the resting EKG, the stress test will also show some ST segment depression or could have some T wave inversion as well. All right. Now, another thing that will be tested will be the troponin and the cardiac enzyme. So these are the things that will be required in order to identify the patient probably has an MI. And of course, we want to make sure that we are carefully diagnosing the patient, or the doctor is ruling out that, hey, this is not really an MI, this is an angina pectoris type of pain. So what's going to happen here? In the angina pectoris type of pain, the troponin is normal in stable and unstable type of angina. Okay, troponin is within normal limits when there is unstable or stable angina. Okay, because there is no significant damage to the heart muscle yet. Okay, however, this is only going to be elevated in myocardial infarction. So that will give us a huge assessment between the two, either the MI or the angina pectoris type of pain. Now, let's talk about the cardiac catheterization, which is that invasive procedure, which will really give us a better picture of what is going on inside the muscle or the heart tissue. Okay, so this will now also take a look into the coronary arteries, rather, to see if there's any blockage, and it will involve the injection of that dye to facilitate visualization through the X-ray. Okay, and the findings that we really want to capture here is to check for the coronary artery patency. That is what we are looking for. Patency of coronary arteries. So if there is such finding, maybe some stenosis or maybe a partial block of that thrombus into that coronary arteries, then this will be identified by this cardiac cath. Now, if there is a blockage during the cardiac catheterization, then the cardiologist will probably proceed with the angioplasty. Okay, they're going to perform the angioplasty right then. As soon as they discover that there is a blockage, they probably would put a stent or maybe no stent at all in order to restore the blood flow. Again, to restore the blood flow. All right, so that's the purpose of the cardiac catheterization. It will help visualize where the blockage is, or if they find a blockage, they can do the angioplasty to allow much more of blood flow to that diseased coronary. To allow blood flow to the myocardium that is affected. Now let me get rid of this. We're going to proceed with the CKMB. Oh yeah, did I talk about the CKMB? I believe, yeah. Okay. All right, yeah, I think I did that one. All right, very good. Now, we're going to talk about the treatment interventions here. There are several treatment modalities that we need to know. But at this point, we're going to talk about the immediate treatment that needs to be done when the patient has that acute chest pain. So what are we going to do here, nurses? We're going to have to assess and relieve the pain. We're going to have to provide them the oxygen via nasal cannula. And we want to make sure that we are monitoring their blood pressure, their vital signs, their heart rhythm continuously. And our first attempt here would be to administer the nitroglycerin as prescribed to promote vasodilation. And we are also going to maintain rest for this patient and make sure that they are positioned comfortably in semi-Fowler's position in order to allow much more lung expansion and help with the breathing. And of course, we're going to have to do the 12-lead EKG to capture those abnormal ST elevation, ST depression, pathological Q wave. We're going to also need to do some more of the care. Establish the IV access so that we can administer those emergency medication. All right. Now, part of the care is the administration of the medications that are going to really reverse the effect of the ischemia. Okay, so what are these medications that we can administer in the immediate phase? One of those is the nitroglycerin. This is the potent vasodilator, and it can be given in many forms. It could be sublingual, it could be a IV, all right, it could be infusion. And again, the mechanism of the nitroglycerin is to facilitate dilation, vasodilation. Do not forget that, guys. When there is peripheral vasodilation or coronary artery dilation, this can decrease the heart's workload. Heart's workload. And in turn, this will also decrease the demand for O2 because it's not working hard, right? When there is vasodilation. And so there is such reduction in the demand. There's also a reduction in the need for oxygen and reduction in their contraction of the heart. Okay, so this is going to be given immediately once the patient has the angina attack. Again, we don't want to prolong the ischemia. Now, another medication that we'll be expecting to be administered is the aspirin, which is that antiplatelet medication, which is going to what? Reduce clot formation. And you're not going to sit on this one. We want to make sure that this is given right away to prevent the clot formation, because when the clot is growing inside that coronary artery, the more it will cause problems because it will block the passageway. Instead that it was partial, now it grow bigger. So that will complicate into an MI. And so on top of the aspirin, we're also going to expect the administration of anticoagulants. And I'm talking about heparin here, which is going to be given as an IV infusion. All right? IV infusion, heparin. Okay, let me write that down. Heparin. Heparin IV. And the reason for that is to prevent further clot formation. And this would be used in the emergency setting, especially in the acute care setting, for those patients that may have unstable. Remember about the unstable angina? The pain can come in, it comes and goes like all of a sudden. And we really want to make sure that any possible complications will be prevented, okay, with the use of the anticoagulant heparin. Now, for the other medications in the acute phase, we will probably see the use of the beta blockers as well. Remember that the beta blockers can reduce the heart rate. It can also reduce the oxygen demand, and it can also prevent recurrent angina episodes. Prevents recurrent or prevent recurrent angina episode. Why? Like I've said earlier, it will help decrease the contractility of the myocardium. So its workload is decreased, right? I mean, it's not working hard around this time once they're given the beta blocker. So this will in turn lead to a much decrease in the need to get oxygen. Now, another medication that you will see in the treatment will be the calcium channel blockers. You will see the calcium channel blockers as well. You'll probably see the diltiazem during the acute phase. This will help relax the blood vessels and also reduce the cardiac workload. Relax the coronary artery and also the myocardium, the heart tissue itself. So that's the reason why the calcium channel blockers are also effective. Now, in the long term, or to manage the patient's chronic angina, we are going to expect that the patient will be given a prescription to prevent occurrences of blood clots. So you will see there the clopidogrel or the Plavix, or it could be that ticagrelor. Let me erase that. Ticagrelor or the Plavix. And again, the mechanism of these medication is to prevent the platelets to clump together. And this will really prevent the future formation of blood clots, and it will reduce the heart attack risk. Now, part of the care in the long term will be the administration of the statins. So you will see the simvastatin medications, the lipid lowering medication, in order to stabilize the atherosclerotic plaques. And also this will reduce the progression of the coronary artery disease. Now, we're not done yet. There's still more medications in the long term. We will see the ACE inhibitors here, like those Pril drugs. This will lower the blood pressure. It will also decrease the heart's workload. And the same thing with the ARBs, or the angiotensin receptor blockers. They're going to lower the blood pressure and also reduce heart workload. Okay. So, in summary here, just looking into this list kind of looks so summarized, right? Yeah, I did that on purpose because it can be very overwhelming just looking at those. How many are those? Like 9 medication groups? Yeah, that's a lot to memorize. And so the goal here, why we are talking about the pharmacologic treatment, is to identify which of these medications will be used during the immediate phase. Okay, during the immediate phase, what we need to do is what? Vasodilation. What else? We want to prevent clots with the use of the 325 milligrams aspirin. Prevent blood clots. And the same thing with the heparin, especially for those patients with the unstable angina pectoris. The pain can come back anytime. We want to make sure that complications will not progress. Of course, the beta blockers, the olols, and the calcium channel blockers. So these are the immediate medications that will be administered, okay? The rest of them at the bottom, they are for long-term use, okay? For maintenance. So just want to present this to you so you understand the differences between the pharmacological therapies. Now let's talk about the surgical management of angina. We're almost there to the NCLEX questions. So what are the things that we need to know about the surgical procedures in angina pectoris? Well, let's take a look into the first one, which is the percutaneous coronary intervention, or known as the PCI. So what is this? Basically, the procedure will involve the use of an invasive procedure, angioplasty, which is a minimally invasive type. It can open the blocked or narrowed arteries. Opens, blocked, or narrowed AC. So what is the procedure here in the PCI? So basically the PTCA is under this category as well, guys. All right. So there will be insertion of the catheter into the blood vessel, especially the groin, or it could be the arm, or maybe the wrist. And this is going to be advanced. It will be threaded into that coronary artery that is blocked. Okay. And this will now inflate the balloon. Okay. Here we go. Once the catheter is situated against that plaque, so the balloon will now be inflated to push the plaques to the sides. So it will open up the narrowed blood vessel. Okay. So in the PCI, the cardiologist might decide whether to put like a mesh or maybe a stent in order to keep the blood vessel open and to prevent re-narrowing of the blood vessel. Okay, so they might decide that. Okay, now let's talk about another procedure here. Let me just remove that. Another procedure is the CABG, which is the coronary artery bypass graft, which is very extensive type of surgery. Yeah, this will really require a lot of recovery time of the patient. It's a major surgical procedure that will really create a new pathway for the blood flow. It will involve anastomosis, new blood vessels that will be connected to that diseased myocardium. Okay, and so they're gonna have to harvest that blood vessel from the leg maybe, or the artery from the chest or the arm, and it will be grafted into the coronary artery. So it will bypass the blocked section. Okay, so this will bypass the blocked section. All right, so that's the purpose about the CABG. All right, now also, we're going to have to identify that the CABG is very risky. It's very risky, guys. It will cause massive bleeding during the surgery. Also, after the surgery, it can also lead to infection and also stroke, heart rhythm problems, atrial fib, kidney problems, probably because of the changes in the blood flow during the surgical procedure, and maybe some graft failure. So these are the things that you need to keep in mind once you have a patient with a CABG. Now let's move forward to the other procedure here, which is what we call as the enhanced external counter pulsation, or known as the EECP. Again, that's the enhanced external counter pulsation, EECP. Have you encountered this one before? Have you read this in the books? Well, this is a procedure that is non-invasive. Okay. This is a non-invasive procedure. It will improve the blood flow to the heart by using external cuffs. Uses external cuffs. And where are these cuffs going to be applied? These are going to be applied into the lower extremities of the patient. They are going to be synchronized in with the heartbeat. Okay, so it will look like this. So let me zoom in. The EECP is basically going to involve the application of those cuffs in the lower extremities. So it looks like one of those sequential compression device to prevent the DVT. But the purpose here is to allow blood flow to the heart by syncing the patient's or synchronizing the patient's heartbeat with the inflation and the deflation of the cuff. So this is non-invasive. So it involves the application of the cuffs around the legs, the buttocks, and again, it will be in synchrony with the heart rhythm to supply blood to the coronary arteries. So this is only suitable for those patients with chronic stable angina. That's the only drawback. It will only be applicable to those patients with chronic stable angina. It will not work for the other types. Chronic stable angina. Why is it doing like that? That's kind of weird. I'm not know what's going on with my pen. All right. Now, let's talk about another procedure. We call it the transmyocardial laser revascularization, or known as the TMLR. What is this? This is typically used for those patients with severe angina, intended for severe angina. This is weird. Why is it doing it like that? Feels like I'm having a double vision right now with that kind of stroke. I apologize, but actually that wasn't cool to see. All right. Now, again, that is our TMLR. This is going to be indicated for those patients with severe angina and for those patients that are not candidates for the traditional PCI or the CABG. So they're going to be using this kind of procedure instead. Transmyocardial laser revascularization. Now, the risks involved for this TMLR, it can lead to, let me just restart my pen. Hopefully that will resolve that. Okay, so one of the complications or risks will be, oh, thank goodness, it's working, arrhythmias, or it can lead to pericarditis. It can also lead to bleeding, guys. All right, so the TMLR will actually look like this. I'm sorry, I should have placed that in here. So it will look like this. It involves laser, the use of that instrument that will actually help revascularize the area. Okay, so take a look at this. That's kind of sophisticated, right? So that laser will be applied into the heart. Okay, and the reason for that is to allow it will help in holes that will be about 1 millimeter in diameter. Okay, so it will cause the formation of new blood vessels. So that would be cool to really reperfuse that area where there is ischemia. Okay, so this is the transmyocardial laser. Now moving into the next procedure here, which is the coronary artery laser revascularization, or no, coronary artery stent placement, which is the most common procedure. This is going to be done together with PCI, like I've said earlier. This will involve the placement of a stent to keep the artery open. And it will have similarities. This will look like that. Okay, so the stent will be advanced into the area where the stenosis is, and this will be placed against the plaque to allow widening of that lumen. Okay, and the reason for that is to allow blood flow to the diseased muscle, okay, to provide blood supply. Now, there's also risk involved with the stent placement. It could recur, it could narrow as well, and there will be some clot formation within the stent. So the patient the patient that will be getting the stent procedure, they're going to be getting anticoagulants, okay? So they're going to be using anticoagulants to prevent blood clot formation. There's also that complication that they're going to have some allergic reactions because of the medications or materials used in the stent. There's also the risk for bleeding, also kidney damage because of the contrast media dyes. Okay, so let me write those down. The risks for the stent placement would be bleeding. Another is renal damage. And the reason why there is renal damage because of the contrast dye that's being used. And if there is no rehydration, if we're not really flushing their system, then it can cause permanent damage to the kidneys. They might also develop some allergic reaction because of the materials that are used. They could also develop blood clots during the procedure. Again, we can prevent that by the anticoagulation. Okay, before we're going to have to proceed, may I remind you that we are inviting you to enroll in our NCLEX review, which is going to help you out. We have lots and lots of prep materials that we're offering. We have the 3,000 NCLEX style questions and 10 hours of animated videos, dedicated animated videos. And on top of that, we also have the on-demand lectures, and we have the study books as well. You can access this for the entire 6 months of your subscription. And yeah, we just want you to be more confident before taking the NCLEX. So hurry up and make sure you visit our website. Now let's go back to the lecture. Where are we at? I guess we're here. Okay. Now, I want you to be ready. Here we go. Our first question of the day. The nurse provides education for a 48-year-old male patient who has a new diagnosis of unstable angina. The teaching included the proper use of nitroglycerin sublingual tablets. For each statement, click to specify whether the statement indicates understanding or no understanding of the teaching provided. All right, let me just take a look real quick. All right, looks like our view is not obstructed. Okay. All right, the question states, the nurse provides education for a 48-year-old male patient who has a new diagnosis of unstable angina. The teaching included the proper use of nitroglycerin sublingual tablets. For each statement, click to specify whether the statement indicates understanding or no understanding of the teaching provided. So this is our multiple choice matrix style. I'm sure we're waiting for this kind of test item. Now, I really want to see your answers here. First statement by the patient, I will place the nitroglycerin tablet under my tongue and let it dissolve completely without chewing or swallowing it. Number 2, I can take as many nitroglycerin tablets as needed until my chest pain goes away. 3, I will take my nitroglycerin tablet with a glass of water to help it go down easier. 4, If I don't feel relief after taking the first dose, I will wait 5 minutes and then take another dose up to 3 doses before calling 911 if needed. And 5, I know I should sit down and rest before taking the nitroglycerin to prevent dizziness or fainting. And number 6, nitroglycerin prevents clots from forming and obstructing blood flow to my heart. So guys, I really want you to identify whether number 1, okay, so what is number 1? Does it mean that the patient understood the teaching? It said, I will place the nitroglycerin tablet under my tongue and let it dissolve completely without chewing or swallowing it. Okay, so let's reveal the answer. The correct answer for number 1 is understanding. It shows that the patient, or there is evidence that the patient understood the teaching on how to properly take the medication. Okay, so make sure that they place the tablet sublingual. We're talking about sublingual tablet. Placed under the tongue. It should be dissolve to dissolve completely under the tongue. Sublingually. All right, guys, I just want to refine here because this is like the very what do you call this, very generic intervention. Like, yeah, you can put it under your tongue, but we want to refine this intervention because some of these patients probably have dry mouth, right? So what are you going to do to effectively deliver the medication if they have a dry mouth? What are you going to instruct to your patient? What would you do? Okay, so because this is very common, very gross or generic nursing intervention or instruction. So what if they have a dry mouth? What will you instruct to your patient? Well, before they're going to take the sublingual tablet, make sure that they are taking a little sip of water. So have them take a sip of water first to moisten their mouth. Okay, make them do that before they take the tablet. Have them take a little sip of water to moisten the mouth and also the area under the tongue, so to facilitate dissolution of the tablet. Because if their mouth is dry, then the tablet will not dissolve, right? Does that make sense? So make sure you include that in the teaching, right? This is a very common intervention, and this might be asked in your NCLEX. It would be much more descriptive, much more in detail. And I like to get into the details, guys. All right? Because if the patient's mouth is not wet, how it's going to be dissolved? None. It's not going to be dissolved. The medication will not work. It will just prolong the chest pain. All right? Make sure you give them a little bit of water to take a sip of that. Make sure that it's moistened to allow dissolution of the tablet. Let it dissolve completely. All right. Now let's talk about number 2. I can take as many nitroglycerin tablet with a glass of water. Okay, what did it say? With a glass of water. Oh no, I can take as many nitroglycerin tablets as needed until my chest pain goes away. What do you think about that? It is going to be marked as no understanding. Okay, we're not supposed to do that. The patient should only take 1 tablet sublingually every 5 minutes with a maximum dose of 3 tablets, right? Only 1 sublingual tablet to be placed under the tongue every 5 minutes in between if the patient's pain still persists, with a maximum dose of 3 tablets. All right? Now, what about number 3? I will take the nitroglycerin tablet with a glass of water to help it go down easier. Guys, remember, we're talking about the sublingual tablet. We should not let them chase that with a glass of water. No water to be swallowed after they place the tablet under the tongue, okay? Because once the medication will be flushed down into the GI tract, well, what do you think? There is going to be less efficacy of the medication because the drug under the tongue will be easily absorbed because of the blood vessels that will help in the absorption in helping the absorption of the nitroglycerin. Okay, so they're not supposed to swallow it, they're not supposed to chase it with water. So we're going to indicate that as no understanding. What about number 4? If I don't feel relief after taking the first dose, I will wait 5 minutes and then take another dose up to 3 doses before calling 911 if needed. Okay, is that correct? Number 4, is that correct? If I don't feel relief, if I don't feel relief after taking the first dose, I will wait 5 minutes and then take another dose up to 3 doses. Yeah, that's what I said earlier. So this definitely indicates that there is understanding of the dosing procedure and the importance of asking for emergency help if the pain persists after the 3rd dose. So make sure that they're going to call 911 if the chest pain is not relieved after the 3rd sublingual drug. Okay, so this is going to be understanding column. Okay, now let's take a look into number 5. I know I should sit down and rest before taking the nitroglycerin to prevent dizziness or fainting. What about that? Is that understanding or no understanding? I know I should sit down and rest before taking the nitroglycerin to prevent dizziness or fainting. Remember, guys, that the nitroglycerin is a potent vasodilator. It can cause dizziness. So make sure that you're going to let them sit or lay down on their bed before taking the nitroglycerin because they're gonna end up dizzy. Okay, so make sure they do that, and that is going to reflect understanding. Okay, and this is to prevent what? Prevent dizziness and fainting. Okay, now what about number 6? Nitroglycerin prevents clots from forming and obstructing blood flow to my heart. Again, nitroglycerin prevents clots from forming and obstructing blood flow to my heart. Does it prevent the blood clots? Does it? Well, unfortunately, guys, it doesn't prevent the formation of blood clots. It only is going to help the dilation of the blood vessels. So this is going to be assigned under no understanding. So there are 3 answers under no understanding and 3 answers under the understanding column. Okay, guys, how do you find this test items? Is it helping? Well, I hope so, because we definitely need to know the different mechanisms, the drug action of the nitroglycerin, how to prevent the side effects or how to mitigate the side effects, how to, what do you call this? How to correct the patient if they're probably gonna tell you something else, all right? And the instruction to make sure that they will call for help if in case the chest pain doesn't go away. They need to call the EMS, the 911. Get some help right away because it might not be angina anymore. It could be a much more of maybe MI, or it could be an unstable type of angina, which is no longer responsive to the therapy. Okay? All righty. Okay. So let's move on to the next question, guys. Question number 2. A patient with angina pectoris has an EKG during a chest pain episode showing signs of myocardial ischemia. Which EKG finding confirms this? Is it A, prolonged QRS duration, B, shortened PR interval, C, abnormal Q wave appearance, and D, T wave inversion? All right. The question is, a patient with angina pectoris has an EKG during a chest pain episode showing signs of myocardial ischemia. Which ECG or EKG finding confirms this? Is it A, prolonged QRS complex duration, B, shortened PR interval, C, abnormal Q wave appearance, D, T wave inversion? All right, let's take a look on the correct answer here. What is the answer for number 2? All right, the correct answer here is, dun dun dun, drum roll please. The correct answer is letter D. The T wave inversion in the EKG is indicative of what? Myocardial ischemia. So definitely the patient's heart, the muscle is, there is a huge lack of O2 in the heart muscle. Ischemia, T wave inversion. Please don't forget that. What about letter A? Prolonged QRS complex duration. Well, when there is prolonged, or let's say widening, this is going to indicate that there is what? Bundle branch block. Could be that. Rather than an ischemia. And this is a finding that will tell you that there is a delay in the conduction of impulses in the ventricles. Of impulses in the ventricles. So that's what prolonged QRS complex duration means. Okay, it signifies that there is what? Possible bundle branch block, not ischemia. It simply means that there is now a delay in the transmission of the electricity within the ventricles. Now, let's talk about the shortened PR interval. What does that mean? Well, letter B. Okay, so we are marking this wrong. This one is correct. So letter B, shortened PR interval, simply means that there is a junctional rhythm or maybe a pre-excitation syndrome. And this is going to be associated with a condition called like the Wolff-Parkinson-White syndrome. Associated with Wolff, with 2 F's, Parkinson syndromes, or White syndrome rather, which is quite a rare occurrence. Okay, it's not myocardial ischemia, guys. What about the Q wave? C, abnormal Q wave appearance. Remember about what I said earlier? The pathological Q wave simply means that what? What does that mean? Pathological Q wave. What did I say earlier about that? It means that there is what? Myocardial infarction. Pathological Q wave. myocardial infarction. Not ischemia, but already an infarction. Simply means that there is now tissue death, okay? Or there is already a significant myocardial cell death. Let's just put it that way. Cell death. All right? Pathological Q wave signifies that there is myocardial infarction or an ongoing, or there has been a significant cell death caused by the MI. All right? So guys, these are very important key points as far as the EKG changes between the MI and the angina. So please don't forget the T wave inversion for the angina, whereas there is Q wave appearance in MI. There is that ischemia, or no, there is infarction that has occurred already. Okay, so I want you to be able to differentiate between the different abnormal EKG readings. Now let's talk about the next question. I hope that you can still see this one because I tried my best to accommodate everything in one screen. And so this is what I really, this is the drawback. This is the disadvantage about using the PowerPoint when we are just like kind of manually presenting the material. It's not like tabs that we can open. So this is the limitation, guys. So let's try our best here to answer this question. So the question stated, the nurse in the medical surgical unit received a phone report from the ED about patient for inpatient admission. Jane Doe, a 38-year-old female, was admitted to the medical surgical unit following an episode of chest pain that occurred 6 hours ago at her home. She describes the pain as substernal, radiating to her left shoulder and left arm. The pain was severe and lasted for about 5 minutes before subsiding. She did not experience any relief until the pain naturally subsided on its own. During the episode, she also experienced shortness of breath, mild dizziness, and palpitations. Upon admission to the ED, her vital signs were recorded as follows: blood pressure 145/90, heart rate 95 beats per minute, respiratory rate 20 breaths per minute, temperature 98.6 Fahrenheit or 37, oxygen saturation of 99 on room air. The nurse assigned is planning the care for this patient. Now, for each nursing action, click to specify whether it is appropriate or not appropriate. So this is one of those multiple select type of question. Okay, while you are answering this, let me have a sip. Excuse me. All right. All right, waiting for your answers right now. So carefully read those tiny fonts because I tried my best here. I really tried my best to accommodate all the characters. And again, at disadvantage of just using a PowerPoint to present the actual scenario and the test question for the... Okay, so I want you to answer this way, guys. Make sure that you enumerate all those answers from 1 to 7 and then just indicate each item, whether it's appropriate or not appropriate. Okay, so let's take a look into number 1. Obtain a 12-lead ECG during the episode of pain. What do you think about that? Obtain a 12-lead ECG during the episode of pain? Yes, that is appropriate. Why? It can help identify the ischemic changes inside the heart during the episode of angina. So this is very important for us to obtain in order for the medical provider to diagnose and also guide their treatment. this is appropriate. And most oftentimes there will be standing orders for us to perform stat 12 lead EKG PRN for chest pain. All right, make sure we do that. Now, what about number 2? Advise the patient to avoid taking nitroglycerin if pain occurs at rest. Advise the patient to avoid taking nitroglycerin pain at rest. Well, the correct answer for that one, advise the patient to avoid. Are you supposed to tell them that? To avoid? No, that is not appropriate. The reason that this is wrong, it's because we're not supposed to tell them to avoid. We're not going to withhold the medication either when they are having the pain. Okay? Regardless of the pain, whether it happens during at rest or with activity, we're going to have to administer the medication. And the reason for that, to prevent further ischemia. Okay? Prevent further ischemia. We are going to administer the nitroglycerin. All right. You're so fast, guys. I'm still in number 2. What about number 3? Maintain bed rest and place the patient in semi-Fowler's position. Do you think it's appropriate during the acute phase? Yeah, of course. We're gonna put that under appropriate nursing intervention. The reason for that, it's because the bed rest alone is going to reduce the myocardial oxygen demand. All right, it will reduce the oxygen demand, and the semi-Fowler's position can also help improve their respiratory function and oxygenation. Okay, now for about number 4, encourage the patient to eat a large meal to ensure they have energy. Let me take a look into your answers. Okay, looks like not appropriate for having a large meal. Okay, so the correct answer for number 4 is not appropriate. Remember about that costs that I mentioned earlier in the previous table. Remember about the costs. One of the causes for the stable angina pectoris, it could be caused by a heavy meal. So we're not going to encourage the patient to consume a large meal. This is wrong. So this is not appropriate nursing action. Okay? Because when they have a large meal, what do you think? What do you think can happen to the heart muscle if they are eating a large meal? Remember about the diversion of the blood flow. Okay? Diversion of blood flow from the heart. Blood from the heart to the GI tract. From the heart. And then to the GI tract. To the GI tract. There is redirection. There is somewhat kind of like a shunting. Yeah. So there is a detour of the blood flow. Instead of focusing into the heart muscle, yeah, a full meal can detour the blood flow to the GI tract. Now, let's talk about number 5. Advise the patient to take deep breaths and perform the Valsalva maneuver to alleviate pain. Let me take a look into your number 5. Not appropriate. Let me see. Yeah, that's good. I'm seeing not appropriate for number 5. Well, that's good. That is the correct answer. We're not supposed to teach them to do the Valsalva maneuver. They can do the deep breathing, but not Valsalva. Why? Let me just put it here. Not appropriate. Why Valsalva maneuver is not indicated or not appropriate? Because the Valsalva maneuver can decrease the venous return to the heart. Okay, let me write that down. Valsalva maneuver. Whoops. Sorry about that. Valsalva. Here we go again. Valsalva maneuver can what? Reduce, or it reduces venous return to the heart. So when that happens, when there is less blood going back into the heart, well, it will also reduce the cardiac output. Reduces cardiac output. When this happens, it can worsen the ischemia. So it's like a very vicious cycle, guys, if we are going to let the patient do the Valsalva maneuver. With the Valsalva maneuver, it can stimulate the vagus nerve. What do you think will happen if the vagus nerve will be stimulated? When they bear down, especially when they're very constipated. Have you tried this? When you are constipated, you're sitting on the toilet for probably 2 hours and nothing has been passed. You're still straining, you're bearing down while you're watching TikTok. Do you feel like you're getting lightheaded while you're bearing down? When there is vagus nerve or vagal nerve stimulation, what can happen is that it can also cause a decrease in the heart rate. It can also decrease the blood pressure. When that happens, when there is going to be a drop in the blood pressure, it can compromise the blood flow to the organs. Again, it will lead to worsening the ischemia. All right? The heart rate will drop, the blood pressure will drop when there is vagus nerve stimulation. Or let me just reword that one, vagal nerve stimulation. Vagus nerve stimulation. It will what? It will cause the heart rate to drop. It will also cause the blood pressure to drop. With the blood pressure dropping, it will compromise the blood flow to the organs, especially the heart. It will worsen that ischemia. And so I'm just going to introduce you right now to the need for us to make sure we will provide bowel care to our patient, especially with the angina pectoris. Bowel care, or let's say stool softeners, to prevent straining and to prevent Valsalva maneuver. To prevent vagal nerve stimulation. I'm sorry, guys. My brain is so occupied like this slide. It's way too occupied. Again, we're gonna need to increase the fiber. Okay, this is a new one. We're gonna increase the fiber in their diet. We're also gonna need to encourage, or we'll ask for stool softeners for this patient in order to prevent straining in their stools and also to prevent vasovagal stimulation caused by the Valsalva maneuver. All right, so that's very important. Don't forget that the NCLEX could trick you into asking these very minor questions in very detailed questions. So don't forget that. That's a key for you to pass the NCLEX. Just same thing with the nitroglycerin. Make sure that their mouth is wet before you administer the sublingual tablet. Okay, let's take a look into what's number one? Obtain EKG. Yeah, that's appropriate. Maintain patient. That's not appropriate. Bed rest, appropriate. Number 4, encourage patient to eat large meal, not appropriate. A patient, deep breaths, Valsalva, that is wrong. Encourage the patient to engage in physical activity to assess endurance. Oh boy, the nurse is so excited to allow this patient to go home. No. Number 6 is not appropriate. We're not supposed to do that. Make sure that the patient is in complete bed rest in the acute phase. Do not allow much more straining into the heart muscle. Okay, they should be placed on bed rest to prevent worsening of the angina and to prevent severe ischemic events. Now let's take a look into number 7. Administer oxygen by nasal cannula as prescribed. Of course, that is appropriate. We're going to supplement the patient's O2 when they will get hypoxemic. All right. How do you like this test question? Actually, I find this easier than the multiple choice. What do you think about the next generation? I find it easier. Same thing with the bow tie. I love it. I like answering this type of questions. The multiple choice sometimes can be very cryptic. Sometimes not all the data are available there. And so multiple choice is very challenging, guys. Yeah, to some degree, it can be very challenging if there is limited information. But for the next gen, easy to spot. But O2 is 99%. I know, 99%. But it's not really about the saturation as well. Okay, so here, let me clarify this one for you, AJ Ike TV. Even though the patient may have a 99% O2 saturation, it doesn't mean that we're not going to provide the O2. We're going to wait for them to be hypoxemic. We want to make sure that they're going to maintain that high level of oxygenation because of the hypoxemia. Okay. All right. So that's the reason why we're going to have to administer the oxygen by nasal cannula as prescribed. We don't want to wait for the hypoxemia to set in. All right. So the same thing will apply when we are encountering a patient with MI. We're not going to wait for them to have low O2. No, we're not supposed to wait for the hypoxemia. Give the O2 supplementation as soon as we can. All right, let's move on to, virtuous lady, but we must know content for such questions. Correct. That is accurate. And when you have the NGN questions, you really need to peel your eyes. There's so many distractions, just like when you're looking into the medical electronic record. Yeah, I like that. You know, I want to spot those errors. I want to spot those abnormal findings. Lab tests, I like those kind of stuff. All right, let's move forward here. Again, all right, number 4. I'll just proceed with number 4. A patient with angina is taking nifedipine. What should the nurse instruct the patient to do? Is it A, check blood pressure monthly, B, weigh themselves daily, C, inspect gums every day, and D, limit green leafy vegetables? Question number 4. A patient with angina is taking nifedipine. What should the nurse instruct the patient to do? Is it A, check the blood pressure monthly, B, weigh themselves daily, C, inspect gums every day, and D, limit green leafy vegetables? What's your answer here, guys? A, B, C, D. Check blood pressure monthly, B, weigh themselves daily, C, inspect gums every day, and D, limit green leafy. Okay. Looks like there's a delay, such a delay with Simon. I can't see your answers yet. Or is there a problem with the connection? Okay, I'm seeing Darren Roback answering letter A. Check blood pressure monthly. Are you sure? Monthly. Is that appropriate? Nifedipine. What is nifedipine, guys? I want you to recall what nifedipine is. The correct answer here is letter C. Inspect gums every day. Let's go through this options. Letter A, check blood pressure monthly. So guys, if you're not familiar with the side effect or the adverse reaction to the nifedipine, the best way to eliminate those distractors, those erroneous test questions, is to do by elimination. This is my technique. If I don't know the material and I just didn't read that information before. And so I would just, oh boy, this is going to be rough. So what I'll do, I will start by eliminating the options. Letter A, check blood pressure monthly. Do you think that this is going to help the patient if they're going to monitor their blood pressure monthly? This is not going to help them in tracking how their blood pressures are the heart rate, is the heart rate stable? No, it's not going to help. So we're going to eliminate that one. Okay? Not monthly. They should be doing it more frequently. There should be daily checks in their blood pressure. So this is going to be wrong. What about letter B? Weigh themselves daily. What is the nifedipine? What is that? This is a calcium channel blocker, CCB. It can what? Relax the blood vessels. It can also decrease myocardial contractility. It will lessen the strength of the myocardial force. So I would say that the heart muscle here is slightly weaker than normal when they are taking the CCB. There's also going to be a drop in the, probably not really drop. I would say maybe a slight decrease in the blood pressure, because sometimes a drop in the blood pressure could be misinterpreted. So I'd say probably slight drop in BP as therapeutic drug effect. So these are the things that need to be are the known therapeutic effects. Relax the blood vessels. It will decrease the myocardial contraction. It can slightly drop the blood pressure. Now, we don't really need to tell them to weigh themselves daily, because it's not going to cause retention of the fluids inside their body. So we're going to eliminate that one. What about letter C? Inspect gums every day. Or let's take a look into letter D, because myself, I'm considering that I'm not aware about the side effects. So I'm not quite sure about letter C. Let me proceed with letter D. Limit green leafy vegetables. And we never heard about that limitation of the green leafy vegetables in the diet when taking the CCB. So you will know, hey, this is wrong. So I'm left with just one possible correct answer. Inspect the gums every day. That is the correct answer, because the nifedipine can cause gingival hyperplasia. A dry mouth as well. So we're going to do the inspection daily and massage the gums. To prevent the gingival hyperplasia. Okay? That's quite tricky. If you're not quite familiar with the side effect, then do it by elimination. Let's move forward to question number 5. A patient experiences a headache after taking nitroglycerin for angina. What should the nurse advise? Guys, we're transitioning into regular multiple choice this time because we need to know the specifics. We don't want to have those extra distractors this time, so you can retain the very important concepts. So we're back to the normal multiple choice. A patient experiences a headache after taking nitroglycerin for angina. What should the nurse advise? Is it A, use acetaminophen or ibuprofen for this common side effect? B, avoid nitroglycerin if a headache occurs? C, drink several glasses of water with the medication? And D, lie flat to relieve the headache. I'm seeing letter A. Very good. That is the correct answer, guys. You can advise the patient to use what they have available at home. Use the acetaminophen or the ibuprofen for the treatment of the headache. The headache can go away. It can be easily treated with the mild medications. All right. Letter B, avoid nitroglycerin if a headache occurs. That is counterproductive if we are going to select B. Yeah, it is very common, guys, because of the vasodilatory effect. Headaches are occurring because of vasodilation of cerebral vessels. There is vasodilation of cerebral vessels. That's why they're gonna experience that headache, okay? Easily treated by over-the-counter pain relievers such as acetaminophen or the ibuprofen. Now, if you had answered letter C, drink several glasses of water, it's not going to prevent, or it's not going to treat the headache at all, okay? Several glasses, that's kind of vague, right? If you're going to be given a choice that is vague, eliminate that one right away, especially, okay? Several glasses, we don't know exactly what's the rationale for that. It's questionable. Yeah, it's a red flag. Remove that one. Letter D, lie flat to relieve the headache. Well, since there is vasodilation, lying flat can worsen that. We want to make sure that our patient will be at least like 30 to 35 degrees angle, but not flat, okay? This can worsen the headache. Worsens headache. All right, let's move forward to the next test question here. Question number 6. An initial step in treating a client with angina. The physician prescribes nitroglycerin tablets, 0.3 milligrams given sublingually. This drug's principal effects are produced by A, relieves spasms in the heart's outer layer. B, increases oxygen demand of the heart. C, dilates peripheral blood vessels. D, enhances heart muscle conductivity. Question: as an initial step in treating a client with angina, the physician prescribes nitroglycerin tablets, 0.3 milligrams given sublingually. This drug's principal effects are produced by A, relieves spasms in the heart's outer layer. B, increases oxygen demand of the heart. C, dilates peripheral blood vessels. And D, enhances heart muscle conductivity. What's your answer? You answered letter C, peripheral blood vessel dilation. That's the correct one. Letter C. Dilation. That is very important. Why? When there is dilation, okay, here's my apple pie heart, okay, and we have the aorta. And then the blood vessels in the peripheral circulation are going to be dilated, right? So let me just kind of simplify this so you'll understand the effect of the medication to the heart. So supposing this is going to be dilated, peripheral dilation, dilated. So dilated arteries, arterioles, dilated veins, dilated venules. There is widespread dilatation of the blood vessels. What do you think can happen to the vascular resistance, the blood pressure in those blood vessels? What do you think can happen to the blood pressure? Will it go down or will it go up when you're giving them the nitroglycerin? All right, I really want you to answer this question, guys. What do you think can happen to the blood pressure or the systemic vascular resistance if we are giving them the nitroglycerin? I want to see your answers. Type in your answers, please, in the chat box. What do you think can happen to the blood pressure, systemic vascular resistance? It is going to be increased, or is it decreased? It will be down, right? Because of the vasodilation. The lumen of the blood vessel is going bigger. There is less pressure, right? So when there is less pressure, this will cause the heart to work lesser because there is less resistance, right? Less resistance for the ventricle, right? The left ventricle or the right ventricle will not work harder this time because there is lesser resistance, okay? Please keep that in mind about giving a patient with a vasodilator, especially nitroglycerin, okay? This is very important. That's why I'm really focusing into the multiple choice right now, because this is quite complex. If you do not really get to the nitty-gritty of the medication, you will not be able to understand the other mechanics. So again, if you're giving them the vasodilator nitroglycerin, this will cause a massive vasodilation to the blood vessels all over the body, dilation of the veins, venules, arteries, arterioles, and it can eventually lead to a reduction in the workload of the heart. So if there is reduction in the workload, do you think this will benefit the patient with a angina pectoris? Yes, it will benefit them because it will not work harder in pumping the blood. Okay, so there is what we call as decrease in afterload, reduced resistance. All right. Now, there's also dilation in the venous system. And so the delivery of the blood back to the right side of the heart will be somewhat kind of slowed down. It's not going to fill the heart really rapidly. And so it will allow the blood to take its little time to go back into the heart. And this is also going to reduce the preload, which is the filling. Okay, so this can also benefit the heart in a patient with angina pectoris. It will decrease the filling. It will also decrease the resistance for the ventricle to overcome. All right, guys, in my experience as a brand new med surge way back, yeah, I actually was so amazed by how the nurses worked when I was brand new. We had this patient that had a fluid volume overload. So the isonos were kind of neglected. And so one morning, this patient went into a pulmonary edema, blood pressure was skyrocketing, hypoxemia. And this nurse who was the charge was really good. She immediately called the medical provider and talked to him. Hey, our patient is fluid overloaded. We need to get an order for nitroglycerin. Yeah, immediately, like around after 15 minutes after the application of that patch, the blood pressure went down, patient's shortness of breath went away, and boom, that was quite effective intervention for this patient. So we averted at least the code to happen because of that quick critical thinking. And so that's how amazing this nitroglycerin can work for such cases. But then again, you got to be careful when you're administering the nitroglycerin because it can cause blood pressure drop, hypotension. So don't forget this important concept. All right, let's take a look into the other options here. Relieve spasms in the heart's outer layer. If we are talking about heart's outer layer, this is basically referring to the pericardium. Does it do that therapeutic effect? No, it will not deal with the pericardial layer. It's not going to do that. The vasodilator will work on the dilation of the peripheral blood vessels and also the coronary arteries. We are marking this wrong. Now, B, increases oxygen demand of the heart. Does it? Demand is increased after the administration? No, it reduces. So this is wrong. The nitroglycerin reduces oxygen demand. All right. What about letter D? Enhances the heart muscle conductivity. What does that mean? It doesn't impact on the muscle conductivity. All right, let's move forward with the next question. All right, before we go to do that, we are inviting you again to enroll to our course at Stancoast and NCLEXcoaching.com. We have a comprehensive review course for you. We have that on-demand videos, on-demand animated videos. We have the study guides, and we aim to build your confidence. So make sure you enroll to our course. All right, so for more details, please check the description box below. Thank you. Number 7, the client is scheduled for a percutaneous transluminal coronary angioplasty to treat angina. Priority goals for the client immediately after the PTCA should include A, minimizing difficulty in breathing, B, ensuring stable blood pressure, C, reducing heart muscle contraction, D, preventing blood volume deficit. Question again, the client is scheduled for a PTCA to treat angina. Priority goals for the client immediately after the PTCA should include A, minimizing difficulty in breathing, B, ensuring stable blood pressure, C, reducing heart muscle contraction, D, preventing fluid volume deficit. What's your answer? The correct answer here is what? Letter D. Why? We're talking about the PTCA, percutaneous transluminal angioplasty. And this is going to involve the injection of the contrast media. All right. Well, what is the relationship or the association between the contrast media and letter D? Well, the contrast media can lead to what we call as diuresis. It has that osmotic diuresis type of effect. So the patient will end up with less fluid volume in the bloodstream. And so it's very important for us guys to encourage oral fluid intake post-procedure. But if they cannot tolerate oral fluid intake, then we're going to have to administer IV fluids to replenish the fluids in the vascular compartment. All right. So letter D is going to be the correct answer. Prevent fluid volume deficit before or because the patient's contrast media, the contrast media that they receive will lead to osmotic diuresis. So that is the focus of the care after the PTCA. Why not letter A, minimizing the difficulty of breathing? This is not expected in a patient post-PTCA. Not expected. What about letter B? Ensuring stable blood pressure. With the PTCA, the blood pressure hasn't been known to be a problem, but it doesn't mean that we're not going to monitor the blood pressure. We still do, but it's not one of the main concerns post-procedure. Letter C, reducing heart muscle contraction. It is actually going to increase the contractility of the heart muscle. Once there is a reestablishment of the blood flow, there is going to be increased contractility, not decreased. And why there is increasing contractility? Because of the reperfusion. There is now reestablishment of the blood flow. So that is why the myocardium will function a whole lot better after the procedure. It will be able to pump the blood effectively. All right. So that's the correct answer. Letter D, preventing fluid volume deficit. Do not forget about the osmotic diuretic effect of the contrast media. All right. Now let's move on to the next question, number 8. The physician refers the client with unstable angina for a cardiac cath. The nurse explains to the client that this procedure is being used in this specific situation to A, to open and widen blocked coronary arteries, B, to assess the extent of arterial blockage, C, to bypass obstructed blood vessels, or D, to evaluate the heart valves and muscle. Question states, the physician refers the client with unstable angina for a cardiac catheterization. The nurse explains to the client that this procedure is being used in this specific situation to A, to open and widen blocked coronary arteries, B, to assess the extent of arterial blockage, and C, to bypass obstructed vessels, and D, to evaluate the heart valves and muscle. Your answers, please. I'm seeing letter B's from Virtuous Lady and AGI TV. Okay, what about the rest? All right, T. The correct answer is letter B. Very good. It is a diagnostic procedure. Cardiac catheterization. It is going to assess the extent of arterial blockage. That is its primary reason. To determine the severity and the location of the blockage. Location of blockage. And the patient has unstable angina. And the reason why they're going to need the cardiac cath, this is to assess the extent of the arterial blockage. Why not letter A? Why is A wrong? To open and widen blocked coronary arteries. This is not the function, or this is not the desired, this is not really the reason why a cardiac cath is done. Letter A is accomplished by the PCI. Remember about the percutaneous coronary intervention, that it will involve the PTCA, insertion of the catheter, will allow that balloon to inflate, to push those plaques to the sides. So that's for letter A. But cardiac cath doesn't do that, okay? So this is wrong, this is correct. What about C? To bypass obstructed vessels. This is only accomplished by the coronary artery bypass graft, cabbage. All right, what about letter D? To evaluate the heart valves and muscle. What is that? This is also possible in the cardiac catheterization. Okay, this is correct, but secondary purpose of cardiac catheterization. Only secondary. So the primary reason why cardiac cath is done, it is to assess the extent of the arterial blockage. Alrighty, moving on to the next. 9. Which of the following symptoms should the nurse teach with unstable angina? Teach the client with unstable angina to report immediately to the physician. Let me reread. Which of the following symptoms should the nurse teach the client with unstable angina to report immediately to the physician? Is it A, a change in the pattern of the chest pain? B, pain during sexual activity? C, pain during an argument? D, pain during or after a physical activity? Is it A, change in the pattern of the chest pain? Or B, pain during sexual activity? C, pain during an argument? D, pain during or after a physical activity? Should the nurse teach the client with unstable angina to report immediately? Okay, don't get confused. Be careful with selections here. The correct answer for this item is letter The correct answer is letter A, a change in the pattern of the chest pain. This is important, guys. If there is now a change in the character, could be the pattern, this can indicate that the patient may have worsening coronary artery disease. So maybe there is now a much severe extension of the plaque, or possibly there is now a wide area, or let's say the thrombosis has affected greatly that blood vessel. Okay, worsening coronary artery disease if there is a change in the pattern of chest pain. If you answered letter B, pain during sexual activity, well, this is expected, right? Expected. And this can also be manageable with medication. Manageable with medication. Yes, the patient can take nitroglycerin before they can engage into a strenuous type of activity at home, right? I'm talking about a patient that has been medicating themselves at home for quite some time. They know that they have the angina pectoris, so they know what really needs to be done in case they have to engage in a strenuous activity, maybe an exercise, maybe a sexual activity. So before they're going to engage with that kind of stressor, they can take the nitroglycerin tablet to prevent the vasoconstriction. Okay, so they can do that. Now, what about letter C? Pain during an argument. The same thing. It is also expected and also manageable by taking the nitroglycerin. Okay, it's also stress that can be addressed by taking the nitroglycerin. Now, if you answered letter D, pain during or after physical activity, what does that mean? Well, it is also expected, right? During and after physical activity, they're going to end up with the pain because of the stress. This is expected. Again, this is manageable. However, if there is a change in the pattern of the chest pain, this is somewhat going to need a much more of a medical intervention. Acute care will be needed for this patient. All right. Let's move forward to the next question. Number 10, following a diagnosis of angina pectoris, a client reports being unable to walk up to 2 flights of stairs without pain. Which of the following measures would most likely help the client prevent this problem? A, climb the steps early in the day. B, rest for at least an hour before climbing the stairs. C, take a nitroglycerin tablet before climbing the stairs, or D, lie down after climbing the stairs? The question is, following diagnosis of angina pectoris, a client reports being unable to walk up to flights of stairs without pain. Which of the following measures would most likely help the client prevent this problem? Is it A, climb the steps early in the day, B, rest for at least an hour before climbing the stairs, C, take a nitroglycerin tablet before climbing the stairs, and D, lie down after climbing the stairs? Remember what I just said in the previous item? If they know that a possible stressor can lead to a vasoconstriction, can cause pain during or after the activity, they can do something about it. And that is what? Taking a nitroglycerin tablet before climbing the stairs. That is the answer. Okay? This is expected. And the patient already said here, or it's being reported, the client reports being unable to walk up two flights of stairs without pain. So you're actually going to teach the patient what to do in order to prevent this problem from happening. So you can advise them to take nitroglycerin tablet before climbing the stairs. If you are letting them do letter A, climb the steps early on the day, no, it doesn't impact pain prevention. Doesn't prevent pain from occurring, because it can happen anytime during the day, right? So it doesn't mean if it's early. All right, you have to get them to take their medication first before they engage with that strenuous activity. Now, rest for at least an hour before climbing the stairs. Resting doesn't prevent the pain. Resting before the activity will not prevent or does not prevent the pain. Okay. Now, if you had answered letter D, lie down after climbing the stairs, would that be sufficient? It will not prevent as well. Does not prevent or address its post-occurrence. It does not prevent pain. So basically the question here, guys, is to test you if you're able to teach the patient properly on the therapy, okay, what they should be doing before they engage in a activity that could cause chest pain. And this is to let them take that nitroglycerin to prevent the vasospasm or prevent the narrowing of the coronary artery. Okay, so we are in the preventive mode this time, not about responding to the pain, but we are on the preventive side of nursing. Now let's take a look into 11. A 63-year-old client has Prinzmetal's angina. To reduce the risk of coronary artery spasms, which type of medication is the physician most likely to prescribe? Take a look here. A 63-year-old client has Prinzmetal's type of angina. To reduce the risk of coronary artery spasms, which type of medication is the physician most likely to prescribe? A, beta adrenergic blocker. B, angiotensin converting enzyme inhibitor. C, inotropic vasodilator. D, calcium channel blocker. Your answer, please. Coronary artery spasms. Prinzmetal's type of angina. Okay. type of medication most likely to prescribe. Remember about what I said earlier during the first few slides there? Okay. Remember about that medication that will prevent the spasms? What was that medication? That is correct. Letter D, calcium channel blocker. Okay. That is it. The medication will relax the blood vessels. And this is not something that the nitroglycerin or ordinary nitroglycerin will be able to do. Okay, so this is a special property that the calcium channel blocker can exert onto the spastic blood vessel. Okay, so only the CCB. All right. Now, if you had answered letter B, beta adrenergic blocker or beta blocker simply, this is going to decrease the oxygen demand. It can decrease the oxygen demand, but doesn't prevent spasms. Does not prevent spasms of the blood vessels, of the coronary arteries. All right. What about letter B? Angiotensin converting enzyme inhibitor. This is only going to be useful in managing the hypertension, but not the spasm. It doesn't have that property. Does not prevent blood vessel spasms. All right. Now, what about letter C? Inotropic vasodilator. Well, this is only going to be effective in treating short-term heart failure treatment. And this is not going to be helpful in treating this patient that has Prinzmetal's type of angina. So we're back to the calcium channel blocker. Guys, don't forget about that. Prinzmetal's angina, think about the calcium channel blocker. Moving on to the next, number 12. The nurse is ambulating a client. After ambulating 50 feet, the client experiences chest pain. What should be the priority interventions by the nurse? Is it A, sit the client down, B, get the client back to bed, or C, obtain ECG reading, or D, administer sublingual nitroglycerin? All right. The nurse is ambulating a client. After ambulating 50 feet, the client experiences chest pain. What should be the priority intervention by the nurse? Is it A, sit the client down, B, get the client back to bed, C, obtain ECG, D, administer sublingual nitroglycerin? Whoa, good for you guys. You answered letter A. Very good. That's the correct answer. Initial priority intervention. Answer is letter A. Why? We want to reduce the oxygen demand. With stopping that activity, this will also reduce the demand. Have them sit down. Okay? So that is our first priority here. Once they settle down, then possibly our next answer would be letter D. Okay? We can do that. And then do the EKG or probably get the client back to bed. In this situation, it's very important that we are going to do this in a very successive manner. Make sure that we are doing one at a time. So you're going to reduce the O2 demand or to reduce the physical activity first, then followed by giving them the medication, and then get them back to bed, or we're going to have to obtain the EKG reading. Okay, all of these are good interventions. These are good interventions, but we are being asked about the high priority here. What should be the priority? What should be the first? It didn't say really first, but if we're going to be asked, or if it says priority, then we are going to have to categorize them according to what should be done first. Okay. Alrighty. Well, we are inviting you again to enroll to our course at www.stancoast.NCLEXcoaching.com. We do have our courses there. We have 3,000 NCLEX questions. We're offering the audiobooks as well, study guides, and we have the on-demand videos that you can access 24/7 for 6 months. And this will also this will include the 200 NGN test questions as well. So please enroll now. Thank you. Moving on to the next question, number 13. A 59-year-old female client is experiencing chest pain at rest that is unresponsive to nitroglycerin. The physician diagnoses unstable angina and alerts the nurse that the client will require treatment with immediate surgical intervention. Which treatment is most effective or appropriate, rather? I'm sorry. I replaced the words. Let me reread. A 59-year-old female client is experiencing chest pain at rest that is unresponsive to nitroglycerin. The physician diagnoses unstable angina and alerts the nurse that the client will require treatment with immediate surgical intervention. Which treatment is most appropriate? Is it A, cardiac catheterization, B, echocardiogram, C, heart transplantation, D, percutaneous transluminal coronary angioplasty? Okay, we're talking about a patient that has what? Chest pain at rest that is unresponsive to nitroglycerin. Unstable angina, that is significant information. Client will require treatment, not diagnostic. Guys, we are wanting to treat the patient, not diagnostic. So look for a surgical procedure that will treat. Unstable angina. All right. The correct answer here is the PTCA, percutaneous transluminal angioplasty. All right, that is the correct answer because this can what? Alleviate the blockage. It will remove, or it can open up, opens the blockage. It can also restore the blood flow. Remember about what I said earlier about cardiac cath? That is diagnostic. What we need here is a treatment, a surgical procedure that will treat the patient's unstable angina. So we want something that can remove the blockage and also to restore the blood flow and also oxygenation. Restore blood flow and oxygenation. All right, so that is letter D. If you answered letter A, that is wrong. It's diagnostic. It will only check the extent of the blockage, right? With that injection of the dye, excuse me, it will it actually will just help visualize the areas where the blockage is with the aid of that contrast media. But it doesn't allow or it doesn't do the restoration of the blood flow. Okay. Echocardiogram. Do you think that echocardiogram can do that? It's non-invasive diagnostic procedure. It will not restore blood flow. So you're going to eliminate that as well. Heart transplantation. This is going to be appropriate for, excuse me. My throat is so itchy. Appropriate for end-stage cardiac disease. It's not going to be appropriate for acute treatment, okay? So heart transplantation is not appropriate for acute treatment. It can help, but again, this is only indicated for end-stage cardiac disease, not on a patient with unstable angina, okay? So we are going to select letter D. Okay, number 14. The nurse is teaching a client about angina. Which statement by the nurse would be most accurate regarding the primary treatment goal? Again, the nurse is teaching a client about angina. Which statement by the nurse would be most accurate regarding the primary treatment goal? Is it A, reversal of ischemia, B, reversal of infarction, C, reduction of stress and anxiety, and D, reduction of associated risk factors? Question is on a patient with angina. Statement by the nurse would be most accurate regarding primary treatment goal. I mentioned this way back during the start of our lecture today. Remember what was the goal that we mentioned earlier during the lecture? What would be the most accurate statement about primary treatment goal? Oh boy. What would be the primary goal? We are going to answer. Virtuous lady was quick. The correct answer is letter A. That is the primary goal. Reversal of ischemia. We are not going to prolong the ischemia. By correcting that, we want to administer the vasodilator immediately. We are not going to prolong the decreased tissue perfusion. So that is why that would be the most appropriate priority goal, primary treatment goal. What we're going to need to do here is to what? Decrease oxygen demand and to increase O2 supply to the myocardium. Oh man. We missed it. No worries. Right. Remember that when we are treating a patient with angina pectoris, yeah, it's important that we're going to do the reduction of the stress anxiety. That is what we do in the long term, okay? So reduction of stress anxiety, this is going to be done for long term. This is more of preventive, okay? Okay, preventive measures. But then again, primary treatment goal usually would be to reverse the ischemia. That is the first, okay? Reversal of infarction, would that be possible? No, that is wrong, because infarction is irreversible. This is permanent, irreversible infarct. There's also cell death. So there is no more going back after the cells have been dead for quite some time. Cell death, no more recovery from that one. This is permanent. So what we're going to do is to reverse ischemia. What about letter D, reduction of associated risk factors? This is also important, but this is also long term. Again, when we are talking about long term, it will be more of preventive measure. Preventive measures. All right. So what slide are we at? We are on slide 584. Okay, let me just show you real quick about that slide where I started. Treatment goals, guys. Here we go. Alleviate acute episodes, correct O2 supply-demand imbalances, and we're going to have to prevent disease progression, long-term management. So just going to show you that. So this will stick to your subconscious that our treatment goals basically would be to alleviate acute episodes, and this is to reverse the ischemia. Right. Going back to our scenario, we are on page 384. So I believe this is it. Okay. Moving on to number 15 item. A client with angina pectoris has a stat electrocardiogram performed during an episode of chest pain. The nurse reviews the ECG and notes myocardial ischemia. This would be displayed as A, increased QRS duration or widened QRS, B, shortened PR interval, C, pathological Q wave formation, and letter D, T wave inversion. Let me reread the question. A client with angina pectoris has a stat electrocardiogram performed during an episode of chest pain. The nurse reviews the ECG and notes myocardial ischemia. This would be displayed as A, increased QRS duration, B, shortened PR interval, C, pathological Q wave formation, D, T wave inversion. Please don't forget, we already talked about this earlier. Angina pectoris, EKG, myocardial ischemia. Remember about that key wave that we talked about? The correct answer here is dun dun dun. The correct answer is letter D. T wave inversion. Remember about that. When there is now ischemic change, this is represented by the T wave inversion. Okay, so that basically means that there is reduced blood flow to the heart muscle. Okay, if you had answered letter C, pathological Q wave formation, this is much more of extensive injury. So the patient now has what? An MI, right? There is infarction. So we are going to eliminate that. What about letter B, shortened PR interval? What does that mean? This is junctional rhythm, okay? And if we had letter A, increased QRS duration, this is the bundle branch block. We actually had this type of questions earlier. I just kind of changed or replaced the words here. I just replaced the words. So this is quite the same test questions that we had earlier. All right. Let's see. Number 16. The nurse is evaluating, dead cells. Infarction. Miss Virtuous lady. That's right. Number 16. The nurse is evaluating a client experiencing angina pectoris. Which of the following are traits of the substernal chest pain associated with this condition? Select all that apply. The question states, the nurse is evaluating a client experiencing angina pectoris. Which of the following are traits of the substernal chest pain associated with this condition? Select all that apply. Is it A, occurs without a specific cause? B, radiates to the left arm? C, lasts less than 15 minutes? D, typically occurs in the morning? E, relieved by rest and nitroglycerin? And F, triggered by exertion or stress. Substernal chest pain. So this is basically reflective of a stable type of angina pectoris. The typical angina pectoris in this case. So what would be that? What would be those options you should be selecting? All right, the correct answer is here. This is select all that apply. Don't waste your answers. The correct answer correct answers are letter B, letter C, letter E, and letter F. All right, so let's take a look. Occurs without a specific cause. Well, this is mostly associated with the MI, right? Mostly associated with the MI. So we are eliminating letter A. What about letter B? Radiates onto the left arm. Yeah, remember about the table? It can radiate to the left arm as well. What about letter C? Lasts less than 15 minutes, which is typical for the stable angina. That's correct. Typically occurs in the morning. What do you think about that? What is that type of angina that occurs in the morning? This is what? Possibly going to be MI or the variant type. Variant angina pectoris, or it could be MI. Now, what about letter E? Relieved by rest and nitroglycerin. Yes, that's another descriptor of the type of pain. So that is another correct answer. And letter F, triggered by exertion or exercise. That is also another correct answer. So we are left with letter B, letter C, letter E, and letter F. Okay. All right, so that's it for the angina pectoris today. That's it for the lecture, and I'm gonna have to see you again tomorrow at 9 p.m. We're gonna talk about another topic. I believe it will be shock, but let me check the note that I got. So we'll be posting that thumbnail for you later on. So I really thank you for your participation for today's lecture discussion, and I hope that you've learned a lot from some concepts. Maybe this is something new for you, but I hope that you are gaining more information today. Yeah, it's kind of like a lot to digest, but I encourage you to go back into this video and do your own diligent study as well. Make sure that you follow through with those NCLEX questions related to the angina pectoris, because yeah, this can be a tricky one. It could mean that, yeah, we often think that angina pectoris is very easy to answer, but actually it's not. If we're going to miss out on those very tiny details, we can get the questions wrong if we're not paying attention to the details. All right, so we want to make sure that you are going to retain these important concepts. This is very important, guys, and NCLEX really want you to manage your patient, especially in a life-threatening condition. Make sure that you are doing your rapid assessment. Make sure that you're doing your careful identification what this assessment is. Is this going to be MI? Is this going to be variant type of angina? Is it going to be atypical or the intractable, or could be unstable or stable? So make sure you do your follow-up study as well after this. So again, thank you for your time and appreciate it. I'll see you again, guys. Take care. Bye-bye.